Hello, good morning, everyone. Very warm welcome to all of you. It's the first day of the Congress. I'm sure you have had a good trip, a good sleep, and you're ready for fruitful discussions. I'd like to introduce Jan Bakker, the Editor-in-Chief for Journal of Critical Care, Professor at Erasmus Medical Center University in Netherlands, and also Professor Pontificia Universidad Católica de Chile. And Jan will start with the first case.
And introduce yourself.
I will. My name is Katarzyna Kotfis. I am a senior consultant in anesthesiology and critical care. I work in Poland, work at the Pomeranian Medical University, and I'm also the national consultant for anesthesiology and critical care in Poland.
Okay, let's start. It's about moral distress, and there is, let's say, different moral distress. You can have moral distress in family members, but also in intensivists. And so we mix it a little bit. I use the... and we have two. One is a combination of three cases, but the next one is one patient. So this is two patients. One is an 80-year-old that had not woken up after 2 weeks after a cardiac arrest with more than 30 minutes of CPR. And the family was not informed straightforwardly because it was thought to be too stressful to be upfront. And the second one was a young patient. She was in her 30s and was found in the toilet in cardiac arrest, probably because of an overdose. She was resuscitated, return of circulation, but also not woken up on day 2. And the family was waiting at the bedside for recovery. And so how would you deal? I don't know. Oh, yeah. And the third one is an older patient on the ventilator, also after cardiac arrest. And our exam, the patient has no respiratory actions. And I was about to tell the family that this was probably very bad. And then the neurosurgeon walked in. And the neurosurgeon said, she's very stable and she's doing great. And so we wait for her to wake up. And then he walked out. And the family was cheering and happy. And then he walked out. And I was like, what the fuck? And so I chased him and I stopped him in the hallway. And I said, what the hell did you do there? I mean, I think, to be honest, this patient is close to brain dead. There's no respiratory activity. And he said, yeah, I agree. And I said, you agree? So, I mean, but that doesn't, let's say, align to what you said inside. And, and he said, you cannot take away hope. So how would you deal with these, let's say, 3 cases? So it's basically all the same. It's a dramatic prognosis, short-term and definitely long-term. And there is this feeling that if you are upfront or you do it the Dutch way, that you cause moral distress in the families, or any kind of distress. But I mean, the whole thinking of you cannot be upfront, you cannot tell the patient, you cannot tell the family, oh, I'm very sorry, but there's no hope the patient will die, and stuff like that, because that will cause too much distress. Then I get into moral distress because the, let's say, environment that's created by the hospital, the department, my colleagues, and stuff like that. So how would you deal with that?
I'm coming from the United States, so I understand that there are very different ways to practice depending on where you are. But I would... Okay. But what I would say is my personal approach, my professional approach as an intensivist is sharing the information that I have, the same information that I have with the families, in a neutral way. In other words, so for example, for the first person, I would say it's been 2 weeks since your family member had this cardiac arrest. and we are not seeing any signs of recovery until now, which I assume is what we are going in, right? Non-neurologic recovery. Yeah, and then I would express something I will not say he will not recover from this, but I would say something in the line of, in people as sick as your family member, after 2 weeks, we are getting less and less optimistic about the possibility of waking up.
Oh, yeah. That's indeed my experience in the United States. Waiting for the family to come to the conclusion, so probably this is not going to work. I mean, I had a colleague in the Netherlands, and he would have a family meeting and then talk for an hour and basically say nothing. And then after an hour, the family would say, so you mean he's dying? Yeah, exactly. That's what I mean. And that's what I see in the US. I mean, why not be upfront? Do you ever think that this one will wake up? Ever?
Very unlikely. Very unlikely. Yeah. He's even if he was in the phenotype of the late awakeners, he already passed the threshold. Right.
Exactly.
So no.
So why don't you tell the family? Well, who would tell the family? Like, okay, this is done, over. And what's your experience by doing that? Can you give them a microphone?
Well, sometimes, indeed, it may be a relief for the families because sometimes they wait for long and they've been told many things and many technical stuff too. And sometimes to tell that we cannot do some things, we cannot succeed and so on. What I used to say in these cases is that we are not sure of many things in medicine, but definitely no miracles.
Well, if you say that you're not sure, you cause moral distress, no?
Yes, but I prefer to say sometimes, maybe not in this case, because it's quite clear that I'm not sure of the answer. I prefer to say this to the families sometimes, but in this case, I would say that it's finished. Well, it depends on what you consider as being alive, but definitely not in a ventilator in the ICU. So.
Well, that's an important aspect, the context, because if you have a patient in the Hasidic Jewish family, then a beating heart is more than enough. Don't have to be awake. Can be on a ventilator in a nursing home as long as your heart beats. That's a perfect endpoint. That's causing moral distress with me. You.
I'm from Switzerland. What helps me normally it's to speak with the family and ask what makes happy this person before the accident.
Very good.
And very often they go on the mountains or meet people. And it helps me to explain to the family that in this stage he could, I'll be sure he could not more do that. And after 2 weeks of cardiac arrest, no awakening, okay, we are sure that he will never come home. Not only the same person, but really if he wakens up, he will stay like at the hospital all the time. And very often they arrive to say quite quickly in Switzerland, he wouldn't like that. So it helps me to ask how was him before and what he likes.
That's a very good point. That's what
Absolutely.
I did with this patient, because the chair of the department, the director of the department, was taking care of the patient for 2 weeks. And she said, you don't have to talk to the family because I've been in contact with them on a daily basis. I talk with them on a daily basis. And so it's better not to have a new doctor and talk to them. And I said, but I mean, what the hell are you talking about on a daily basis? And she said, well, the chest x-rays and the labs and the blood pressure. And I said, well, I think it's time I talk to the family because this doesn't make any sense. And they did exactly what you said. So after introducing and talking about what kind of patient is it, I think he was a judge, a very high up judge. And so I asked the question, so if he wakes up, what is the minimum he has to be able to do to make his life worthwhile? Simple question. And they said, oh, we don't know. I mean, we never thought because no one ever asked. And so they came back in the afternoon and they said, well, he doesn't have to move around. He can be in a chair the rest of his life. But what is absolutely necessary, that he reads the New York Times in the weekend and discuss with his friends the content of the New York Times. And I said, I'm very sorry, that will never, ever happen. And I explained why and the numbers and stuff. And then they said, so this doesn't make any sense. Yeah, true. So that was on a Tuesday. On Wednesday, he went to a nursing home. On Saturday morning, his daughter called me that he died. They stopped treatment, did nothing, and he died. And so that's a very important point. Ask what the context is of the patient, not the family, but the patient, to have a meaningful life. You're in trouble with, as I said, Hasidic Jews, because they only want a beating heart. And in New York, they have a contract with a nursing home facility in New Jersey, and they take brain-dead patients, whatever condition, on a ventilator. Within the day that you tell them this is hopeless, nothing will happen, they make a phone call. In the afternoon, an ambulance arrives, the patient is moved to New Jersey. I have only one litigation in New York for malpractice. It was a patient who was brain dead, and the only thing I did is I told the patient, the family, the patient was brain dead. In the afternoon, transported to New Jersey. She survived or lived in what they thought was living. The heart stopped after 2 years. So she was brain dead on a ventilator for 2 years. And the family was incredibly thankful. I met them later on, and they said, thank you for being so upfront, and thank you for facilitating and letting us take the patient to New Jersey, because there's an element, you cannot declare them brain dead, because you're not allowed to transport dead patients on a ventilator. And so then you have to disconnect them from a ventilator. They have to come with a ventilator outside the house. That's a huge thing. I never did that. So I never declared them dead. And, of course, they were extremely thankful for having a dead patient on a ventilator for 2 years. But it's still the same question, what is important? And in one case, it's reading the New York Times, and the other case, it's a beating heart. That causes moral distress with me. I mean, I feel not okay when I transport a dead patient on a ventilator to New Jersey. I mean, what's the point?
You know, on the topic of the beliefs, I think we need a little bit more help from theological scholars, a little bit more, because I see it similarly in our Muslim faith. It's like it's their culture, it's their faith. I'm like, really? Death is an integral part of belief system. And this was never in the scriptures or any text to have how long to do CPR for, how long to do intubation for. And I'm like, for the Islamic belief people, I'm like, if we ask them too much, they'll be thinking, oh, you don't want to help. So it's that kind of situation that comes. And I'm like, we need to modify the way we do shared decision making, thinking that they need to know things the way we think, and equilibrating that difference. And I'm like, that is, so for me it was like, well, that's just not true that they want endless things. So I don't know, like, you know, where we are stuck with the Hasidic Jews too. We don't have them too many in Rochester, Minnesota, but every once in a while they have, and we have had similar experience with, like yours, that they need to be kept going on and on.
But do you have your limits?
So for them, the limits were the hardest one I experienced. It was the 10-3 ICU. And they come from New York. They've come for we're going to try. And those limits, they were eventually intubated. And they were like, well, this is going to go on. But, you know, one of the ways our burnout kind of is we do also 7 days at a go. And
True.
There is going to be somebody from their spiritual, their family, and we'll be recognizing it. And if that's all we know about them and understand them, then...
But you don't refuse?
Not for those specific patients. We don't have the load you have, but in the ones I remember, they got everything according to their belief system.
But it's just not...
Yeah, absolutely.
Okay.
I was at the bedside of a dying patient.
Yeah.
And she was not on a ventilator. And she was completely unrestful, in pain, she was not communicating with anyone because she had no conscience, but she was sitting up and as if she were in pain. And so the nurse called me, "Can you come to the room?" All the family was in the room, and I said, "Get me some morphine." And then the son got on his phone, and I said, and he said, "Wait." I said, "Wait for what?" "I'll call the rabbi if he's okay with the morphine." And I said, "I'm not interested if the rabbi is okay with the morphine because I'm going to give morphine, whatever the rabbi wants. I don't care." And he was like, yeah, but let me finish the call. And luckily, because otherwise it would have been a big fight, the rabbi said, no, morphine increases life. If you give morphine in a patient that is, let's say, not doing well at the end of life, they live longer. And I said, yeah, the rabbi read my study because we show that you indeed live a few minutes longer if you give morphine. But apart from that, I would have given morphine even if the rabbi would not have. That's my limit.
So I'm glad to hear how you dealt with it because they're rare in Minnesota, but the Muslim people are common and they go on forever. But
they can't.
But they can't. So at the end of it, one just has to demystify that it is not part of religious belief, and then just tell them, that's it, we're not going to, and I have done that.
Yeah.
I have done that because it was like easier for me to understand that background. And say, we're not going to intubate here. We're going to do this. Anything aggressive at end of life will expedite dying. And aggressive care at end of life is actually harmful. And framing it that way when you're confident in that way was helpful. Okay, you're the doctor. Here you go. I get it.
And did you have any distress from that?
No.
No?
No, it clarified. It helped them feel better. We are there with them throughout the day. We say hello to them. How are you doing? You're far away from family. Some people have traveled from other countries. So it's that was not distressful. I think the more distressful is when they're left on their own to sort it out.
Okay.
I just wanted to draw your attention to the different levels of moral distress, and some of that moral distress is caused by us as healthcare professionals. So here, in the cases that Jan discussed and everybody discussed, number one was what is going on with the patient. Number two, the family and their beliefs and the cultural background. But to me, a very important bit is the difference in opinions between the physicians. The head of the department saying that this will be going on and giving false image to the family, and another physician, Jan, coming to the bedside and saying this has no success story. This will not end well. So I think that's another voice for a discussion that I think as physicians, as healthcare professionals in teams, we need to discuss first what we collectively think might be happening with the patient. So we're done with that one. Okay, I'll talk about a recent case that we admitted into our ICU. It was a 63-year-old patient with multimorbidity that was admitted to the ICU with septic shock due to diabetic foot. And the infection was so rapid, the patient required limb amputation and other concomitant problems were identified. The patient developed acute pancreatitis, and after 3 weeks of deteriorating case, multiple laparotomies, hemorrhagic pancreatitis, the surgical team said to us, we are beyond care. There is nothing else we can do. We will open the patient. We can do it every single day, drain, do whatever, but the tissues are so fragile. There is no option. There's no option this will heal. And at the bedside, there were two daughters from the very beginning. who were introduced into the process with the patient because they brought him to the hospital, and they were informed by the team members that this is a case. They were informed on a daily basis what is going on, but the discussion with them was clear that the patient would not improve from our experience, and they said that the patient would not want to live without any chance of improvement. Now, sorry, that's just playing up. After those 3 weeks, the son came, the son that had no connection to the patient, and has left home many years ago. The son came requesting more explanation, requested talking to the surgeons. He wanted a conference with all of us, and he was very aggressive and agitated when we told him, as we were informing the daughters, that this case is a lost case and we cannot do this anymore because this is just futile. How would you approach the discussion with the two sides of the family members? Because here, the moral distress caused by the healthcare professionals was, to my understanding, lesser because we agreed on the course of treatment. But the moral distress was ignited within the family, or between the daughters and the son. Can you comment on that? What your approach would be? Go ahead.
Hi, my name's Jane. I work in Ireland as an anaesthetist and intensivist. I think this is a challenging situation. I think the first thing I would most likely do is get all the family members in the one room together. And because I find if you meet with certain family members when the rest of the family aren't there, only parts of the conversation get translated onto the rest of the family members, and they sometimes come with a different interpretation of the meeting than they're all together. Okay, I didn't realise that. I'll hand you back the microphone then. I mean, from our perspective, working in Ireland, it tends to be a medical decision, to end care. But obviously, the physician will feel more comfortable about the medical decision if the family agree with it. Sometimes more than one meeting is required, and a development of trust to actually continue and act upon the plan. And, quite likely there's a bit of underlying guilt with the son who's just kind of come out of the woodwork and he wants to prolong things for a different reason. Guilt may be it.
Yeah, I was going to say it is not unusual to see that strange family members come and they become the source of delay in decision making. What I have found helps me, because that can be very injuring, right? You have a group of the family, the ones that were next to this patient for years, agreeing with the medical team, and then someone who is strange comes and creates disruption. The approach from a place of curiosity, right? He's asking all these questions. He's asking all these. He's demanding all these meetings and all these teams, and coming more from a place of curiosity of, okay, where are you coming from? How would this help you? What is what you're willing to see in here? Because I agree, guilt is probably playing a huge role on this, and here is where I personally also become very stringent with limits. I would say we are going to honor the meetings that you're asking, but we are going to need to come to a decision, and we will have to decide by when. All right, and if they are not committal, then I will put the limit. No later than 48 hours, we are going to need to come to an answer. And I know it's paternalistic, but in many circumstances, because I have seen this in a non-paternalistic model going very badly, like prolonged. And then once you fulfill the demands, guess what? There is going to be another list of 5 demands, then a second opinion, transfer to a different hospital, lack of trust, like all that. So
I agree with you saying that this is a medical decision. This is the way we would approach that in Poland, and this is what we did. We asked a psychologist to the meeting to help us with the situation. Obviously, the son was feeling guilty, and he lived with that guilt for not being with the family member, with the parent for so many years. And it took time. In this case, it just took time. It took repeated conferences. In our department, the family meets with a different person every day. They have an option to meet with the head of the department that delivers all the information during the day, but during the visiting hours, as the ICU is not fully open, then they get the information from different team members. But the front is the same. The approach was the same. So there is no us causing or producing different information to the family. But at the end, you just need a conference with everybody involved. So the surgeons, the ICU physicians, the rest of the ICU team, and the family members on both sides, and the psychologist. So with time, the daughters were able to convince. They haven't seen the brother for a long time as well, but they were able to convince him that this is not what the parent would wanted. This is something that has gone so badly that there is no coming back to the pre-admission state. So this would have been, in the opinion of the two daughters, what the mother wanted for her, just to die peacefully without pain, but not being repeatedly taken into the OR for a next intervention.
A question. What did you mean when you said they have a family meeting with different people every day? Like, who's the consistent team member?
The consistent, it changes every day. The way that on-calls are structured is because of the lack of the physicians. There is the head of the department and a person that leads the ICU, but it is not always the time when the family comes. So there is a chance that the family comes at a time that they are past their daily duty, and they come in the afternoon, they talk to the person on call. But the person on call is involved in the whole process, and they can deliver, basically, and I hope so, the same information that would have been delivered during the day. So that's how it's organized. All right. Thank you very much for this interesting session. Are there any other questions or topics that we would like to address? Anything that you would like to share? Go ahead.
Since we mentioned moral injury for the physicians, I'm just very curious in the 1 minute that we have left. How in the different places are you dealing with that? What are the support mechanisms for intensivists for moral injury?
Well, to be honest, one of the reasons I quit my practice in New York, because I was fighting. I did 1 week, so 7 days, 12 hours, 1 week a month, and I was fighting every day. And that's related to where I come from a very paternalistic system. So we go to the family and we say, this is going nowhere, we're going to stop treatment. And then you give, let's say, room for discussion and stuff like that. But the decision is made. No way out. There's no discussion. We can discuss whether we do it in the afternoon or tomorrow morning. But so that's the Dutch system. And then coming to the United States, where it's like, what do you think? And a family getting, and they have different opinions. Also related not only to, let's say, I wasn't there for the past 10 years and so now I want to be in charge. It's also who's responsible for this. I had a quarrel between a daughter and a brother, and the daughter said, this is not okay. My mother would never have wanted this. You have to stop. And the son said no, and they were quarreling for a week. And then on Monday I took over, and I set them both in the room, and I asked the brother, so why are you against stopping treatment? Do you disagree that your mother didn't want this? And he said, yeah, I don't think my mother wanted this. But do you think I'm going to decide my mother will die? And I said, no, you're not decide. I decide. If you agree, I decide. And he fell to his knees. He started crying, grabbed my hands, and said, I thank you so much for taking responsibility. Because many families in the U.S. think they're responsible for the care, which is not the case, of course. So yeah, the moral distress was not very comforting for me, and one of the reasons I quit my practice.
In our practice, the one thing that really helps us is our lots of colleagues. We're like, when we are like 2 teams and we are 7 days, it gives us a little continuity. And when we are in the difficult case, it'll be like, hey, I go to my colleague and it's like, I have this difficult one. How should I feel this? And also, like, our team structure has the affiliate practitioners, the residents, the fellows, right? So when we are people, it's like, who is talking to the family every day? Shall we go together? How should we build? The nurses want to be part of it. So the time that our schedules were being broken 3 days and 4 days, none of us liked it because we lost that. The day one, anyways, it's like, I don't want to talk because I don't know you, you don't know me. And it can be different for everybody, but I feel like it's an impact when people see me, who the hell are you? And it takes a day to realize I'm in charge of your care here. And but it takes that trust building a day or two and then having those sequence. So that really helps us, having those lots of types of colleagues. And even if they're not rotating, the comfort of being able to call somebody, that is an institutional commitment, I would say.
You know, because of this, I became certified physician coach, executive coach for physicians, to help them with moral distress and burnout. And it's a sad story that you ended up leaving your practice because of that, or maybe happy, I don't know. But yeah, okay. But it is a loss. It is a loss for the system if we don't have the mechanisms to support physicians and clinicians during these kind of processes, because we are losing physicians to the healthcare industry.
Absolutely.
So.
We're done? Okay.
Thank you very much. It was very interesting.